Hello, everybody. Welcome to the Persiska Hematologic Malignancies Tumor Board. Very happy to have you here. Very excited to go through some of these really interesting cases. The cases that we are going to focus on today are all patients with various forms of lymphomas. We have an outstanding panel with us here today to go over these cases. I'm very excited to be amongst them. I'm going to first introduce myself. I'm Dan Pollier from the University of Colorado, and I'd like each of my colleagues to introduce themselves. Dr. Fromm, please.
Hi, my name is Tyler Fromm. I'm an assistant professor of radiology with appointments in abdominal imaging and nuclear medicine at the Washington University School of Medicine in St. Louis, Missouri. I specialize in oncologic imaging with a focus on MRI and PET examinations.
Larry Keston. I am a radiation oncologist in Michigan, in the Detroit area. I work for Michigan Healthcare Professionals and Genesis Care USA. I'm the medical director of the Michigan region.
I am Jeremy Abramson. I am a medical oncologist specializing in lymphoma. I direct the lymphoma program at the Massachusetts General Hospital in Boston, and am associate professor of medicine at Harvard Medical School.
John Pagel. I am the chief of hematologic malignancies and the director of the stem cell and cellular therapy program at the Swedish Cancer Institute in Seattle, Washington.
This is a 78-year-old Caucasian male with a history of stage 4 follicular lymphomas, a grade 1-2, now with recurrence 3 years after chemo-immunotherapy, with a soft tissue masses, osseous involvement, bone marrow involvement, and some moderate lymphadenopathy. So ultimately, we're going to talk about the recommended systemic therapy for this scenario. Let's get a little bit more detail. So the patient presented with symptomatic soft tissue masses and fatigue, and a performance status here of 1. This patient had a history of spinal stenosis, type 2 diabetes, some arrhythmia issues with a pacemaker, no relevant social or family history. This started in 2013. The patient was diagnosed with ileal involvement and had a resection. And in response to this, had 4 weekly doses of rituximab. The patient in 2015 was treated with bendamustine plus rituximab for 6 cycles and had a partial response. In 2017, he was treated with lenalidomide with rituximab for 4 months, who had stable disease, and this was complicated by a rash, presumably from the lenalidomide. In 2018, the patient was treated with rituximab, cyclophosphamide, vincristine, and prednisone for 6 cycles with a partial response. So, Dr. Pagel, can you tell us, is this a typical course or is it atypical? And, you know, in what way, I guess, is what I would be interested in.
Yeah, I'm not sure what's typical in indolent follicular lymphoma and what's atypical. It's a very heterogeneous disease. There's a bell-shaped curve. Of course, most people fall in the middle there. There are people way out in the far ends, people who have the disease for decades and never even actually get treated. That does happen. There are people that have extremely aggressive disease, even though they are told they have an indolent follicular lymphoma. And certainly a lot of that has to do with the pathologic, or I should say, the actual true biologic features and risk of the follicular lymphoma, in particular, perhaps the pathologic grade of the disease. This story here may fit in that bell-shaped curve, but to be honest, it's more on the aggressive side with these multiple relapses that are happening so frequently. Typically, what happens, of course, is that people will present with follicular lymphoma because they have a lymph node that's a bit enlarged. Biopsy is done. They feel perfectly fine. They're asymptomatic, and they end up having a new diagnosis of cancer. And then those people may be watched for a long time. When they finally need treatment by standard criteria, then they get treatment, their disease goes away perhaps for years, may come back, and that on off again pattern can go on for years or even sometimes decades. This is a different story a little bit. It's kind of unusual. There was an unusual presentation involving the bowel. It does happen. The idea, though, of every year needing a different therapy, and many of these therapies are extremely important to give most patients very meaningful remission. So this is not a typical presentation, and one that I'm worried about this patient for lots of reasons, but they've gone through many excellent approaches with very quick relapses.
So that brings up, Dr. Abramson, can you tell us, I mean, what are the criteria by which you treat, introduce another line of therapy? So as we see, this is not Hodgkin. These are not patients who, the responses here are partial responses typically. So, what do you need to see to introduce another line of therapy between treatments?
Patients with an indolent lymphoma like this, we don't consider them curable. Our goal is to use treatment as needed to make their life as long as possible and to make their life expectancy as normal as possible. And the majority of patients with follicular lymphoma will have a completely normal life expectancy. Those patients who progress early on their initial therapy, as this patient did, those are patients who have much higher risk disease and are therefore at much higher risk of actually dying of their follicular lymphoma. And so why do we treat follicular lymphoma? Since it's a disease that people can live with for decades without needing therapy, we look at whether the disease is causing symptoms, either locally due to disease that's pushing on something or causing discomfort, or less likely systemic disease that's causing B symptoms, fevers, night sweats, drenching weight loss, or causing fatigue. We also look for disease that's getting bulky. As we talked about earlier, the criteria in follicular lymphoma, the so-called GELF criteria for therapy would be 3 or more nodes, each larger than 3 centimeters, or any single node larger than 7 centimeters would be a reason to consider therapy, as well as bone marrow infiltrating disease resulting in significant cytopenias would be a reason for therapy. And then compressive disease would be a reason for therapy. And that's really what this patient presented with initially. But at the time of initial treatment or at relapse therapy, we go back to first principles and say, are any of those indications for therapy met? And if not, we would generally observe. Clearly, this patient has had recurrent symptomatic disease and required therapy, and likely does again at this time.
Great, thanks. I think that's a really important distinction for everybody. Those of some of us who treat a lot of different kinds of cancer, there's no tolerance for any speck of a malignancy, and I think that is not the case in follicular lymphoma, where you have to have certain criteria, as you described, to really rise to the level of treatment, and we can tolerate the presence of this disease without treatment. So it's one of the unique parts of oncology. Dr. Fong, can you take us through this CT scan? This is the most recent CT scan that we have to sort of make decisions about.
Sure. Yeah. So we have 3 transaxial contrast enhanced images from a CT scan, 2 in the chest and 1 in the abdomen. And the top right side image shows some enlarged axillary lymph nodes bilaterally. I think we're told that one on the right side measures over 3 centimeters in size. On the lower right-hand image, we have a subcutaneous soft tissue nodule in the right anterior chest wall. And then on the left-sided image, we see, we're not actually told this, but it appears that there are some enlarged para-aortic and aortocaval lymph nodes there in the retroperitoneum. There's a mention of some subcutaneous fat stranding in the upper left anterior chest wall, which we can see on that upper right-sided image. And usually that sort of finding, would more often be something, perhaps post-traumatic or infectious or inflammatory. So, really, we'd really want to look at prior studies and sort of see how these abnormal lymph nodes are changing over time to get a sense of how the disease is behaving. We're also told the patient has an enlarged spleen, which we don't see here, but assuming that there are No other causes for splenomegaly, such as chronic liver disease and portal hypertension. That would be presumed to be another site of involvement as well.
Thank you very much. So this patient has the right axillary lymph node biopsied, and it again is shown to be a low-grade follicular lymphoma, CD20 positive, CD10, BCL6, BCL2, and CD23, Ki67 less than 10%. A bone marrow biopsy is performed, and normocellular involved with the follicular lymphoma process about 15 to 20%. And presumably that was done because of the cytopenias that we see here. Normal renal and liver function, normal LDH. So with this information, knowing the extent of the disease and the history, Dr. Pagel, what would you recommend as a next line therapy?
Well, actually, even Dr. Pollier, before I would do the next line of therapy, I'd get a PET scan here. I think a PET scan would be very important to really make sure that we know what we're working with. This is not a typical presentation of grade 1, grade 2 follicular lymphoma with a low proliferation rate of a Ki67 less than 10%. It's an unusual presentation. But regardless of what that PET scan shows, if it still came back and had low SUV values, I'm going to treat this patient with a relatively aggressive approach if I can. I don't remember the age of the patient, or certainly I don't recognize that the comorbidities or the performance status was impaired here. So I'm going to assume that I can take this patient to relatively aggressive treatment. So I would try to get some therapy that is going to allow us to do that. I want to get disease under control as best I can before I go to a more aggressive procedure, which would either be an autologous stem cell transplant, or even my more preferred approach at this point is a CAR T cell therapy, which has recently been approved in patients like this with relapsed follicular lymphoma. So this would be a patient where I might give salvage chemotherapy to, or a regimen of rice. Frankly, I'm skeptical that the patient's going to have significant long-term benefit to it. And in fact, I might even suggest that they need some other novel therapeutic approach that would be part of a clinical trial. Certainly wouldn't be unreasonable, or even something like a PI3 kinase inhibitor for short term, just something to get disease under control. In some cases, if they had longer remissions or thought to be chemotherapy sensitive, I might do an autologous transplant. I don't think it would be curative in this patient, but it might provide some disease control for a longer term. I'd be most optimistic about trying to get this patient to a CAR T cell therapy. Those can, at least encouragingly in the early data, suggest that these patients can have long-term survival benefits with that type of an approach.
Thank you. So I think the take-home points here are here that, low-grade follicular lymphoma has a very heterogeneous presentation, and it can be an indolent disease course that a patient can live with for a long time with minimal therapy. But as we see here, that is not always the case. And sometimes these patients have a more aggressive clinical disease course that requires more aggressive therapies. And in a patient like this, with multiple therapies over a relatively short period of time and progression, taking a more aggressive approach with a clinical trial or a chemotherapy regimen or a CAR T therapy, perhaps all of which could be consolidated with a transplant, would be reasonable considerations.